Hello and welcome to Health Affairs This Week. I'm your host, Jeff Byers. Today we have on the pod Stacie Dusetzina to talk about new obesity medications. But first, just a quick reminder that today is the last day to submit to our Your Health Policy Wonk If campaign. Finish the sentence and enter to win an online journal subscription for a year. Also, next Wednesday, June 5th, join us for an issue briefing for our June 2024 theme issue on reimagining public health, which will be published early next week. Panels include the dimensions of public health, the public health workforce, and how public health systems can be sustainable and accountable. And now back to obesity medications. Stacie wrote about this very topic for our Health Affairs Insider program that was published this week. If you're not a Health Affairs Insider member, please subscribe. And also keep in mind, this is a rapidly moving space. We're recording this on Tuesday, May 28th, 2024. But excited to get the conversation going. Stacie, welcome to the program.
Thanks a lot. Great to be here.
Yeah, happy to have you here. So one thing we were talking about before hitting record, what do we call these drugs? Do we call them weight loss drugs? Do we call them obesity medications? Like, what are people saying?
I think most people refer to these drugs as obesity medications, although, as you will note, and as we'll probably get into, there are a lot of other indications for their use, and the indication matters. But in the media, we often see people say weight loss drugs, but obesity medications, I think, is probably the way we'll talk about them today.
Right. And so from a non-policy perspective, what's known about these drugs and how are they being used and covered currently?
The way that they are being used is heavily so far. So one of the things that I think is really exciting to see when you are, a drug policy wonk is when there's a new set of drugs that work really, really well for patients, but they have some potential nuances like, they could be used by a very large number of people. They are expensive. These are the kind of interesting policy and access questions that come up for someone like me who's like, oh, how do we make this work? Really effective drugs, really expensive price tag, and who knows what's going on with coverage. In addition, there have been some complicating factors like, the drug makers have been battling with drug shortages for these products since they came onto the market. So we've had issues where people needing the lower level doses for diabetes have had a hard time being able to get those drugs because the demand for the higher doses for weight loss or for obesity have just been substantial. And I think even beyond what the drug makers had been anticipating. So what you see a lot of right now is complaints that people can't stay in a steady supply of these drugs, and also a lot of questions about, like, will their health insurance actually cover the drug for them?
On that, just kind of curious, like from where you sit, have you ever seen something like this in your career where, like, I felt they exploded onto the market and seen about a year or so ago, and now you can't really not hear about them in a way? Like, have you ever seen anything like this?
I think we've gone through a couple of iterations of drugs where we've talked a lot about the potential budget implications for different payers. So things like hepatitis C curative therapies for Medicaid or the Alzheimer's drugs for Medicare. So we've had drugs where, there's been a lot of interest in a specific drug or set of drugs because of the spending implications and access implications. There was literally a South Park episode about this drug or these drugs last week, right? So there is so much awareness of the weight loss and obesity drugs in society. We hear about celebrities using them. We see like specials on Netflix. There's just all kinds of coverage that is not really typical for prescription drugs, but it makes sense when you think about how prevalent overweight and obesity are in our society, how much investment people make in trying to lose weight. It's really not that surprising when you think about how much money goes towards just weight loss and trying to deal with your health in this broader context in the US.
I read a figure today that I did not fact check. Someone else maybe be able to, that about 40% of the U.S. population is obese. Do you know if that's right or not?
Yes, that sounds absolutely correct. And I think that doesn't include the people who would be categorized as overweight, which
Right.
brings our percentage even higher for potentially eligible in medically to take these drugs. Or when we think about the populations that are being studied in the clinical trials, that includes some trials of people who are overweight in addition to people with obesity.
And that's interesting that you brought up how a lot of people work towards weight loss and maintaining their weight, and how much money has been put into that industry and area in general, which honestly I had thought about, but I didn't think, I hate to say it, disrupted. It could disrupt that area in general, even though it's a term I don't love to use as much. But on that, so what are the current issues for supply and demand? We have a lot of people that might be eligible. Can they get it? Can they be covered for it?
Well, it depends on where you get your health insurance is the first part of that answer. Let me step back and say also depends on shortages being cleared. So right now, even if you have health insurance coverage and you ended up paying a small part of that, you may not be able to get the drugs because of drug shortages, although I know the manufacturers are all ramping up their production capabilities so that they can start to better meet the demand. So there is this short-term problem of, we're hearing about people who actually have coverage or they're paying out of pocket and they still can't get access to the drugs. Hopefully that issue will be cleared in the relatively near future. But even once it is, there is a huge question of is it covered for you and how much do you have to pay? So these drugs are expensive. If you were paying cash for them, we're talking about over $1,000 a month for a drug that you're going to be using probably for the rest of your life to maintain that large amount of weight loss that is being reported in trials. So that's a pretty substantial dollars commitment from people. Now, some people will have the drug covered by their health insurance, although we don't know quite yet what that's going to look like across different markets. There have been some really public examples of state employee plans declining to cover it because it was having such a large budget impact on them, and they were going to have to increase premiums for people on the plan just to be able to, make the dollars work. So as we see more and more of this, I think what we'll see is maybe you have coverage now. We'll see if you have coverage in the future as employers are trying to figure out, how to make that math work. It's not totally clear to me what Medicaid programs are doing right now on this as far as coverage is concerned for weight loss specifically. So Medicare has made a guidance available to plans to say, for other indications, you can cover these. So these drugs are covered for diabetes. It looks like for secondary prevention of cardiovascular disease. Just over the weekend, there was news about the use in chronic kidney disease. So those types of indications are covered under Medicare, although the Part D plans that operate the benefit have not yet added the drugs to the formularies the last time I checked. So it can take a little bit of time before the drugs actually get on formulary and are available to people at whatever their cost-sharing arrangement is, a copay or co-insurance. So it's all over the place. I think manufacturers have set up a lot of opportunities to help people get their hands on these drugs. So some of the manufacturers have their own support programs where you can go through their manufacturer website, you can get the drug prescribed for you, and then you can get on their copay support program. So depending on how your coverage looks by your plan, those manufacturers are making a lot of assistance available to help get people started on the drug. But, that's obviously because it pays off for them in the long run to get as many people as possible using the medicine.
Yeah, it would be interesting in a long-term study to see if someone lowered their health costs over a lifetime, because as we know, if someone gets less healthy as we go on, obesity can complicate that. It'd be interesting to see how that changes the calculations. Moving on. So what can consumers expect in this area?
Well, it's hard to say. I think that people are likely to see one of a couple of things happen. One is that you might not have coverage for these drugs if you are, prescribed the medication, you have an indication that fits the bill. You may still find that your health plans aren't covering these drugs, or even if they are, that you're having trouble getting your hands on them because of drug shortages. I think that these are going to be issues that are going to be tackled over time. And one of the things in particular is with the clinical benefits that these drugs are providing, it's hard to think that they won't have broader coverage in the relatively near future. That said, I think there is this big question about who's getting access to them, who's using them, and what are their indications for use, and how much we all pay for that. So, for example, if we had everyone with obesity who, wanted to take these medications, started taking them, it would add a lot to how much we are all paying for our health insurance. So we would probably expect that if everyone had really easy access to the drugs and started them, we would see our premiums go up in the next year or so. And we're already seeing premium increases to try to accommodate or offset some of the increases related to the spending on these drugs. So I think that this is something we're going to see in the next couple of years. Right now, we're already hearing these really high projections of spending on these drugs, again, in the face of shortages and in the face of a lot of people not having good coverage. So I'd imagine that as the shortages get cleared, we'll get a sense of how much real demand there is for them. And, there is this really important question of, what's the long-term benefit, right? So we know that there are these really impressive results from trials on people's health, and that could reduce some types of healthcare spending in the long run. But I think that one of the outstanding questions in my mind is this issue of if people don't take them in the long run and they regain the weight, are you going to get to those outcomes? And, there's fields that study these types of questions, like pharmacoepidemiology. The whole thing is like, what actually happens when you give these drugs outside of trial settings? How long do people actually take them when they're dealing with side effects, when they're dealing with the prices? We don't really know how that's going to look in, what it becomes our new normal. But we'll find out in the next couple of years.
Yeah, I know it wasn't a pharmaceutical intervention, but you reminded me of the Biggest Loser study, which was a weight loss study, which found that a lot of individuals gained their weight back. But again, not a pharmaceutical intervention on that point. But
yeah, and with these drugs, I think the evidence has been fairly clear that the weight loss and weight maintenance is with continued use of the drugs. So once you stop them, there's a pretty small proportion of people who can maintain their substantial amount of weight loss, but it's definitely not everybody. So we see a lot of people who regain the weight, and I think that there are important questions there about, well, what does that mean for the longer term health benefits, even with shorter use?
yeah, so we've kind of danced around the question or danced around the issue of access and cost, which highlights that there's probably a health equity angle to all of this. What are the aspects through the conversation through a health equity lens are you hearing?
Yeah, I think one of the biggest ones is that the people who have access to these drugs right now are the people who can afford to pay out of pocket. So that would put people in a pretty high income category to be spending over $1,000 a month out of pocket on these drugs. And I think there are a couple of key health equity situations that come up. One in my mind is that, with shortages, we have a limited supply of drug and we have a range of conditions that could be treated, some more severe, more urgent than others when we think about potential poor outcomes. So when we think about someone who wants to take these for diabetes, they want to take these because they want to prevent another heart attack or stroke, like those are pretty extreme health conditions that we want people to have access to these effective medications. We also have on the other end of the spectrum people who want to take these medications for more cosmetic weight loss. And we know that is actually a pretty sizable amount of people. The demand for that is pretty high. we could probably all think of celebrities that we've noticed recently who've gotten a lot slimmer, who we don't know all their health situations, but we may think of as not being in that high risk category. So that's a huge equity concern in my mind, is that we get these drugs to the right patients and prioritize access for the people with the highest clinical need. We could also do that with the way we think about paying for these drugs under health insurance. So if you have high need and there's high benefit for you, you pay less money out of pocket. So we make them more accessible and more affordable. Maybe they're a little bit more expensive if you need it for less of a clear indication for its use. Obviously, it has to have an indication, but these drugs have pretty broad indications for obesity and weight loss, in addition to these supplementary indications. One other thing on the health equity front is that we know that Black individuals and Hispanic individuals tend to have a higher burden of obesity-related illnesses. So there's a lot of concern that we are seeing the drugs not reaching people who have the highest burden of illness. And I think that that's something that we have to pay attention to when we think about whose insurance is covering it, who's having to pay high deductibles even when it's covered. Those sorts of equity issues, I think, are really going to stay at the forefront of this topic.
Great. Thanks for that. And so I think some of what I'm hearing, there's a high eligibility for people that could take this drug. With more coverage could potentially come higher premiums associated to those that don't take those drugs. And yet there's probably push from the public and from pharmaceutical companies for these drugs to get covered. Is that about right?
Yeah, all the public polling has, people are pretty adamant that these drugs should be covered and that people should be able to get their hands on them pretty easily. I think one of the issues is people have a hard time with how health insurance works and thinking about those trade-offs. And we almost never wrestle with premiums. It sort of feels boring, right? It's like, okay, nobody likes to make their health insurance decision, but that amount of money that you have to pay or that your employer is paying on your behalf is growing pretty substantially. Like the average premium for employer-sponsored insurance plans for a family is very, very high now. And so if we have a lot of people who start using an expensive healthcare service when they were otherwise not using services, that's going to really put upward pressure on those premiums. And I think one of the things that people, maybe kind of do is they're like, well, the health insurer can pay for it. It's like, well, no, they don't. It's you. You're going to pay for it. All of us are going to pay for it. And that might be fine. It might be something we decide is really worth paying for, especially for these indications that have really clear and substantial benefits. But we have to recognize that that's what will happen. We'll all have premiums go up, and maybe that's a completely reasonable thing to be paying for. But we just need to recognize it. That also means that we need to be cautious about premiums going up too high, because it could mean that people can't afford basic coverage. So maybe some people opt out of having health insurance coverage because they can't afford it now that premiums are higher. Or we have more people who have to pay deductibles or a higher percentage of their share of the drug's cost or other medical services. We just need to recognize we're making those trade-offs when we make decisions about coverage and access.
Yeah, I guess I was just going over the summary and thinking it's going to be a sticky situation kind of going forward. And with that, final question, as we're running out of time, is like, so what actually can policymakers and drug makers expect going forward?
I think we're going to need to expect there to be greater coverage, especially for some of these indications with, really substantial clinical benefits. We need to monitor, what does that mean for premiums? What does that mean for spending? How do we think about getting a better deal for the public, for our payers? One of the things we haven't touched on is the price point in the US relative to everywhere else in the world. We're paying many times what other countries are paying for the same drug, even for these new indications. And I think it's really worth considering how much do we want to overpay relative to our peer nations when we talk about a drug that is going to have such substantial use in the US? And how do we think about doing a better job getting lower prices so that we can improve access without breaking the bank?
Well, on that, appreciate your time. Thanks for joining us today on Health Affairs This Week. To all the listeners, thanks for listening. If you enjoyed this episode, please subscribe, tell a friend about it, and hope to see you next week.